Really am excited to be here and thank you for asking me to talk today. This is a topic that I'm very passionate about. I was trained as a family physician and am a family physician. I worked in sort of usual family medicine practice for a long time. In about 12 years ago, I started to see more and more patients with eating disorders. And I will say this is not something I was well trained in med school and residency. I think I got a total of 3 hours on this. And so it's been something that I've had to educate myself as I go along. And so over the last several years, I've begun to get more and more patients, and I would say now eating disorder patients comprise about 60% of my practice. And there are more patients than that are sort of a weight neutral approach, which gets interesting. So anyway, so that's kind of where I come from. Shannon, go ahead and advance the slide there. Thank you. So I have no disclosures. Nobody pays anybody in family medicine to do things like this. Insurance barely pays us. So, okay, go ahead. So my goals for today are to help you understand patients who are at risk for eating disorders, and the short cheat answer to that is everybody. Secondly, to understand the DSM-5 categories for eating disorders, and those are, I think, very limited and can be frustrating to try to apply to an individual patient, but we'll talk about that. To recognize the signs for warning signs for eating disorders and also some of those physical and lab signs, and then know where to turn for help. Next slide. Perfect. Okay. So I just wanted to make the point that you really can't tell the book by its cover. You cannot tell what a patient's habits of restriction or purging or binging are based on their body shape or size. So I've had patients who are in larger bodies who are eating 200 calories a day and are told sometimes that they should cut down their calories. And that's, physically impossible at that point. And patients who are very thin, who are eating, a very robust diet. So just be cautious about the assumptions that we all make, and make sure you're talking to the patient about their behaviors. Okay, next slide. So patients who are at risk, the stereotype that we all sort of have, I think primarily because of media coverage, is that it's middle-class white females who have eating disorders. That's really not true. I threw in here the statistic of 3-to-1 female to male, but we really don't know. Their patients do not present early. Patients are reluctant to come in for help for eating disorders, for sure. And that definitely applies more to people who don't fit the stereotype because they feel that it just doesn't fit them. And one of the things that we see routinely in patients with eating disorders is that they don't really feel sick. They don't really think that there's anything that not sick enough is a big stereotype in this. And so patients present late. There's a very high representation in transgender and non-binary patients. And I think we're really starting to see more and more of those patients presenting to care since the pandemic. There's a high representation in patients who have mental health diagnoses and also physical health issues, and I'll talk about that a little bit more later. This was surprising to me when I first started doing this work. This is not a problem of wealthy and middle class people. It's very common in patients who have food insecurity, or particularly if they have a history of food insecurity. I have many patients who had really unstable food access in their early childhood, and that definitely can contribute. Males often do not want to come in because they don't think they, quote unquote, should have an eating disorder. Their body image distress often presents differently. A cisgender male oftentimes will come in with a desire to be lean or cut, not just thin, not just skinny. And athletes are at very high risk. I think the ones that I listed there: gymnastics, dance, wrestling, running, those are things we think of, but even, things like football players and across the sports can be affected, and in different ways often. Okay, go ahead. So these are the DSM-5 categories that I'm going to talk about. Anorexia nervosa and the two subtypes of that. Bulimia nervosa, what we call OSFED, which is other specified feeding and eating disorders. It's sort of like the NOS that you see in other things. And ARFID, which is avoidant restrictive food intake disorder, binge eating disorder. And then I wanted to mention orthorexia, which is not a DSM diagnosis, but you will hear thrown around quite a bit. So the first one is anorexia nervosa. Again, in the media, this is the one that you see a lot. A lot of movies out fairly recently that include this. So these three bullet points up top are the DSM criteria. So restriction of energy intake relative to requirements. And that relative to requirements is very important because if you see an athlete who's running 3 hours a day, their energy requirements are very high and they often have trouble meeting those, even if they want to, but particularly if they want to lose weight or change their bodies. So intense fear of gaining weight or becoming fat or persistent behavior that interferes with weight gain. So body dysmorphia and body image distress are a big part of this. That body dysmorphia is that third bullet point, which is they don't see themselves as the way other people see them. So I've had a lot of patients who are, obviously gaunt and cachectic when they come in, but they see themselves as being, grossly obese. And undue influence of body weight and shape on self-evaluation. These patients can be, phenomenal workers, students, have, amazing skills, but they're not weighing that anywhere near as heavily as they are, what their weight is on the scale. There are two subtypes of anorexia nervosa. The first is restricting. So with both of these subtypes, restriction is prominent, but restricting type is pure restriction. Anorexia nervosa binge purge type, primarily restriction, but there are episodes of binging or purging in addition. Go ahead, next slide. So second type we're going to talk about is bulimia nervosa. So with this, binging and purging are predominant. So as you might guess, anorexia nervosa binge purge and bulimia nervosa are really, I think, more of on a spectrum than completely separate identities. And I do see many patients whose eating disorder behaviors evolve over time. So I find these categories to be very fluid, and I'm always reluctant to put a label on it because I end up wanting to change it the next time I see the patient, but of course I have to. So these patients have recurrent episodes of binge eating. There is no specific amount of food or calorie count or anything like that constitutes a binge. Really, what makes a binge is that it feels out of control to the patient. They often are hiding it, isolating, and then with bulimia, they have compensatory behavior. So vomiting, purging is the most common, but definitely I have a lot of patients who use laxatives, a lot of patients who've used diuretics, diet pills, compulsive exercise. And I didn't list on there, I guess because it's not in the DSM-5, but I see many, many patients who use nicotine, amphetamines, stimulants, especially Adderall, those kinds of things as compensatory behaviors as well. And per DSM-5, in order to fit the diagnosis or the definition of bulimia nervosa, they have to binge and purge at least once a week for 3 months. As you can imagine, that's pretty fluid and changes. And again, self-image is unduly influenced by body shape and weight. So body image distress is big on this one as well. Okay, next slide. Okay, third type of eating disorder we're going to talk about is binge eating disorder. The DSM-5 criteria are recurrent episodes of binge eating. And again, that binge is primarily characterized by feeling out of control. They can sometimes eat more rapidly than normal. They eat until they're uncomfortably full or actively in pain. They eat when they're not hungry. Who doesn't do that, though? I'm just going to say. Eating alone, feeling really disgusted, depressed, guilty, ashamed. That is a huge component of binge eating disorder. They have a lot of distress about it. Again, this per DSM-5, it has to occur at least once a week for 3 months, and does not have that compensatory stuff. So, not prominent, at least purging or other compensatory behaviors. So, sorry. Okay, go ahead and next slide. Okay. And then OSFED again is this other specified feeding and eating disorders. This tends to be a lot of things fit under this. So I'm going to skip the first one for a second, but bulimia and binge eating that are of low frequency, so less than once a week or for less than 3 months, would fit into this. And if a patient is purging without binging, I think that's a tough one because most patients feel like that eating is out of control before a purge. So I'm not sure how helpful that one is. But and then atypical anorexia is listed here, and this is something that makes many people in the eating disorders community just grind our teeth, because what it means is that a patient is not at low BMI, but is engaging in all the same types of restriction that a quote unquote typical anorexic would do. We know that their outcomes are just as damaging metabolically. And so it's really a weight biased way to look at the diagnosis. And I'm hoping this will change in the next DSM-5. There's been a lot, or the next DSM, there's been a lot of discussion about that in the community. So, okay, next slide. Thank you, Ashley. um, and ARFID, avoidant restrictive food intake disorder. I think this has been gaining a lot of interest in the literature. It's a really can be a really tough problem, and basically the difference is with ARFID versus the other eating disorders that we've talked about. The body image distress and desire to be thin or change your body in some way are not prominent. They don't have to be completely absent, but they're not prominent. So the criteria are eating disturbance with a failure to meet nutritional needs. And again, it's that energy balance, calories in, calories out. They have weight loss or faltering growth, nutritional deficiencies, dependence on nutritional supplements or enteral feeding, and it really gets in the way of their lives. It's not explained by lack of food, which so many of us see patients with food insecurity now, or by cultural practices, of course, religious fasting or limitations of what you should eat based on those culture and religion do not factor into this. Not due to a medical condition. However, frequently there are coexisting medical conditions and mental disorders that you have to sort out. There are several subtypes of ARFID, and frequently these patients are folks who have had some type of problem with their nutrition their entire lives. And so one of those subtypes is people who've just never been interested in food. So the person who comes in and says, when I was 3, my mom had to stop me and make me eat because I never wanted to do it, and I'd just pass out, if she just let me keep going. So this is somebody, food has always been just a burden to them. And as you can imagine, with additional life events and stresses as an adult, that can really be a problem. Sensory avoidance is the kiddo who textures really bother them, things like that. And that frequently will coexist with autism spectrum and with OCD. So, and then the third subtype is aversive. So these are patients who have had a bad experience with food in some way. So patients who had a severe choking or horrible anaphylactic episode, or I had a patient who couldn't drink water because she'd had a really horrible drowning incident as part of trauma. And so it's very linked with PTSD type of things often for patients. And I put in here secondary body image distress. So I have many patients who presented as typical ARFID and really come in and they say, I want to fix this. I want to fix this. I want to, heal my relationship to food. I want to be able to eat a wide variety of foods. I want to be stronger. I want to, have better nutrition. But as they start to get into recovery and are expanding their nutrition, if they gain weight or their body changes, it can be very distressing. And much of that is the society that we live in, which puts a really immense burden on our appearance. So, but again, body image is not predominant in ARFID ever. Okay, go ahead. Okay, and And orthorexia, so this is a term that you frequently will hear sort of bandied about by people who are in the eating disorder field. It is not in the DSM-5. You can't put it in your diagnosis. But it is really important because it's sort of a subclinical sort of eating disorder in a way. So patients often fixate on eating a very small variety of the right foods. So clean eating would kind of fall into this category. Again, it's a matter of degrees and a spectrum. And this can interfere with social functioning, but I have seen patients I'm thinking of one patient who would really, stereotype orthorexia, would only eat, very specific foods from very specific stores that had been raised organically, et cetera, et cetera, et cetera. And all her friends did it too. And so she didn't present to care until she couldn't conceive because she was not in great health. And this is often associated with excessive exercise. So I think there was a question about, is this the same as atypical anorexia? No, atypical anorexia is really typical anorexia in a larger body, which again, anyway, so next slide. Okay, I've kind of alluded to this a couple of times. Co-occurring diagnoses are really common in mental health. Really, any mental health diagnosis increases the risk for eating disorders, and there's a lot of overlap. We see depression and anxiety, I would say almost universally in patients who have struggles with their nutrition. OCD is common, autism spectrum, PTSD, and again, there's a little bit more OCD with anorexia nervosa restricting type. There is more PTSD in patients with bulimia, but it's not really helpful, I think, as a clinician to know, what goes with what, because they all go together and there's a ton of overlap. When patients have significant restriction, I always tell them a starved brain is a depressed brain and an anxious brain. So they don't have to start with depression and anxiety, but if they are restricting, they will develop those. And I don't know if all of you are familiar with the Minnesota starvation experiment, which was, just a horrific experiment that basically took physically and mentally healthy men and put them through a very limited caloric exposure. So I think they were limited to, it was either 1,200 or 1,800 calories. So not even very severe restriction, but way less than their requirements. And they all developed all of the characteristic eating disorder behaviors, including depression, anxiety. They were hoarding, they were purging, they were restricting food choices. So a lot of these things can be secondary, but you don't know until you begin to work on all of it together. On PTSD, I wanted to make a note that medical trauma is something I see very frequently. And what I mean by that is that a patient will come in. I've heard this story probably 20 times that an 11 or 12-year-old comes in to see their doctor and they're told, oh, well, your periods are irregular because you're too heavy and you need to lose weight. And I see them a decade later when they're, fighting for their lives. And so those kind of off the cuff comments that people make about, oh, well, you just need to, your body is wrong, you need to change it, can be really, really, can have a lasting, frightening effect. And so I think we need to be really careful about how we approach these things with all our patients. Other medical issues can also increase the risk for eating disorders, irritable bowel syndrome, because, if you have horrible cramping and diarrhea every time you eat, of course, it's going to be easier to just not eat, and that can really send them down the road. Celiac and food allergies, again, they start to narrow what they can eat, and that just gets narrower and narrower and until they run into trouble. Many of you probably have seen or certainly read about patients with type 1 diabetes who basically don't use enough of their insulin or any of their insulin, permissive hyperglycemia to allow them to lose weight. And that can be a really tough problem to work on. Increasingly, I'm seeing patients with type 2 diabetes who are on GLP-1s, and that can be a huge problem if their relationship with food is at all challenging. So, okay, next slide. So in general, these are the categories to think about and have in the back of your mind. And I keep my little DSM-5 laminated things so I can kind of have them. But again, I think really what we should be doing is looking at the patient. So when I see a teenager or an adult, I don't ever look at or show them their weight before I start a conversation about what they're doing and what their life is like. I think if you start the conversation, especially with a kiddo, a 16-year-old who has an elevated BMI, they shut down before you ever even have the conversation. And so I usually start with sleep. It seems to be the safest thing. So I say, "Hey, how's your sleep?" And then I ask about, what about your mood? Are you doing things you love? Are you having fun? And then I sort of segue from there into usually recreational drugs. And then, what about nutrition? Do you follow any special diet? Or are there things that you don't eat or think you shouldn't eat? And kind of trying to be really open-ended with those. I ask about if eating is stressful or makes you feel anxious. Do you eat with your friends? Do you go out to pizza? Things like that. And do you worry about your body shape, size, or weight? And I usually always throw all those things together because, again, some patients will be really focused on a desire to be thin. Some patients will focus on a desire to be muscular. Signs that you may see when you're in the exam room, really important that if somebody's growing, that they're not falling off the growth curve. So this is kind of the classic thing where they'll be coming along at their 50th percentile and then flatten and then drop off. It also is just as significant if they're coming up at the 90th percentile and they fall and drop off. And so again, larger body weight patients are just as at risk metabolically. And oops, sorry, I just did something weird. Abnormal electrolytes are something that I really didn't understand how critical that was until I started seeing these patients. So early in my career, I probably saw, 20 patients with eating disorders that I didn't pick up on because I would see a low potassium in a patient in the emergency room. And I would say, oh, they must have, RTA. Well, probably not. Probably they have an eating disorder and there's purging or laxative use. So of course, not all patients are going to want to talk about that or be ready to address it, but it should be top of your differential if you're seeing elevated CO2, low potassium in a patient that doesn't have another obvious reason for it, like diuretics or something. If you see a patient with amenorrhea, again, this should be top of your list. Maybe pregnancy should be first and then this. And so again, runners or other athletes who lose their periods, that is not okay. It's definitely a sign of relative energy deficiency in sport, or you may have heard the term REDS or RED-S. And so it is definitely a sign that their metabolism is suffering. And when they lose their periods, their estrogen levels go down and they're at risk for osteoporosis and stress fractures. And unfortunately, I have several patients in my practice who've had 10, 12 stress fractures. I've seen 19-year-olds with osteoporotic vertebral compression fractures. So we want to catch it early. Okay, next slide. So if your spidey senses start to tingle, you start to get a suspicion that all is not right in terms of their nutrition. It's really important to get a sense of how functionally limiting this is for patient and family. So you want to understand, like I mentioned before, can they do things with their friends? Can they flex with a different environment? Or is this, are they eating only in their bedroom, can't even eat with family, will only eat one or two things, and how distressed the family is. So there is some really interesting research that shows that families of patients with eating disorders, and they're really looking primarily at teenagers and their parents, but those families are under a very comparable amount of stress to families of schizophrenic kids. And so it's an immense stress on the family. And that also applies to adult patients who come in with their partner or their, children. It's very, very stressful for the family. And again, I keep saying this, but diagnostic category is much less important than opening the dialogue. So start to have the conversation with your patients. When I first started doing this work, I was really uncomfortable talking about purging. And, I think it's just like when we're talking about other delicate things, the more you just practice it, ask the questions, the easier it gets to just be very matter of fact about it. And I always say, I'm not here to judge. I'm here to help. Early diagnosis and treatment are critical. So if we're able to catch someone within the first year of their eating disorder, their chance of not having to live with this, really traumatic and difficult illness for the rest of their life is far higher. So So try to catch those teenagers before, ideally when they're still in the home, and ideally if they have supportive parents, because those family-based or family-centered therapies can really be extremely helpful. And also, this is, there are more resources for people who are under 18. It's easier to get them into care. So that's also another important reason to address treatment early. A treatment team should consist of, they need a doc for sure. Obviously, they're going to if they're, seeing their primary care doctor. They need a dietitian, a registered dietitian who really is familiar with and has some training in eating disorders. And not all dietitians feel comfortable doing this work. Same thing with therapists. Even in patients with ARFID who don't have a primary, body dysmorphia or body image distress, it is really hard to change what you're doing at every single meal, every single day, and have, be surrounded by social media that's telling you shouldn't be doing it, and you shouldn't be eating those foods. So I think everybody needs a good therapist who's comfortable dealing with patients with eating disorders. And then psychiatry, usually, not always. Again, if their depression and anxiety are secondary to their eating disorder, the only thing that's going to help is nutrition. But I have many psychiatric colleagues that I work really closely with, and it can be very, very helpful. And when you see the patient, really very, very important to address their depression, how severe it is, and their degree of suicidality. So we know that eating disorders have the highest mortality of any mental health diagnoses other than opiate use disorder. So I see a lot of patients who have chronic suicidality, but every time we're kind of trying to address, okay, how high is that risk? And so really, really important to ask those questions. When a patient has been in restriction for a long time, and I would say, I'm saying primarily restriction because I see it more there, but cognitive rigidity is a huge feature of this. It does get worse with chronic malnutrition. And so when you see a patient who you're trying to get them to make some changes, it can be really hard for them to see any window for flexibility. Shannon, I see a question in the chat. Do you want me to stop and answer those, or?
Let's finish and then we'll have some time for Q&A and then we'll go into the cases.
Okay. Don't let me lose track of your questions. Okay. So, and then in terms of physical health, in my experience, the physical exam tells you more about how bad things are in a patient who's restricting, and the lab work tells you more about how bad things are in a patient who is purging. That's not always the case, but I like to kind of keep that in mind, and I always talk to patients about that. If I have a patient who's sort of the classic anorexia nervosa restricting type, I always say, hey, we're going to do labs, but they're probably going to be fine, and that doesn't mean your nutrition's okay. And so in a patient who's restricting, what you'll often hear about and see are weakness, and oftentimes lightheadedness, syncope, falls associated with that, GI distress and palpitations, low energy, sometimes cognitive clouding, but eating disorders can affect every single system in the body. So there can be a lot of things. I would say those are the most common things I see in people who restrict, who only restrict. Patients who purge, again, it's going to be more what you're going to see in the labs, those electrolyte abnormalities. You can see edema that typically only occurs when a patient has been has been purging for a long time and then gets exposure to IV fluids or something like that. So if a patient has a low potassium, ends up in the emergency room, gets potassium with fluids, they're going to show up with very significant edema. And it really makes them not want to go in ever for treatment in the emergency room or anywhere else. And if anybody wants to know, I can explain that. It's the whole pseudo-Bartter syndrome, and it has to do with adrenal glands. Patients who purge often, as you can imagine, have GERD. They've got esophageal pain, sometimes hematemesis, which can be really dangerous. And GI distress is across the spectrum. Anybody who's doing anything different with their nutrition, even ARFID, even binge eating, as you can imagine, they all have some sort of GI distress. Bloating would be the most common, constipation, but anything. If you see patients with stress fractures and osteoporosis, this should be top of your list. And amenorrhea, like I mentioned. One really important thing to know is that when we see a patient who presents with amenorrhea because of underlying nutritional issues, putting them on a birth control pill does not fix it. It does not help anything. It just hides the sign that we have that something's wrong. And so we should never be doing that. It does not help their bones or anything else. And I'm happy to answer questions about that if anyone has any. And I already kind of covered that next bullet point. Oh, with restriction, the other thing, of course, that you'll see is overt sarcopenia. So they lose muscle mass. They definitely lose a lot of soft tissue fat, and can have decubitus ulcers, pressure sores as a result of that. I think this is kind of funny, and I don't know. I don't even know whether this is in any studies, but I think one of the most helpful things in patients who really restrict is their cap refill. So they oftentimes you can see overt modeling in their extremities, but when you can't, if you just on the back of their hand or on the front of their shin, just see how long it takes. That really is associated with that sort of clamping down and conserving energy toward the center, and our extremities are not considered as essential. So I think how bad that modeling or capillary refill is really gives me kind of an overview. What are we dealing with here? And then I mentioned bone density, EKG, and echo. At some point, everybody who's had any period of amenorrhea, or for male patients, anybody who's had suppression of testosterone should get a bone density. EKG can be helpful. I think for EKG, typically, really what we're looking for is just bradycardia. People will often talk about QTC prolongation, but that is not actually associated with restriction. When you have a suspicion that a patient has an eating disorder, definitely talk to people around them if you can. Parents get a sense of how big they think the problem is, also what their own eating behaviors and diet practices are, and then talk to support people for yourself as well. Okay, next slide, please. Okay, I am good, perfect. I was hoping to be able to launch into this at 12:40. So I know Tara has a case. I have 4 cases to kind of illustrate different types of eating disorders, but Tara, let's hear your case.
Katie, do you want to first go through the questions that are in the
Yeah,
chat?
let's do that.
And then we'll talk about the cases after. So I want to make sure we get these answered. So the first question from Catherine Fleming, what counts as oral nutritional supplements in ARFID?
Basically anything you can get in, right? I mean, typically, really what we're talking about there is things like Boost and Ensure and Cape Farms and those kinds of things. We're talking about, drinks that you can get that are going to give people a broader nutritional exposure.
Great. And then this question from Caroline, I'm interested in hearing more about how GLP-1 or GLP-2s are connected to disordered eating. These seem like very common medications now, and I wonder if there are new trends we should be aware of.
Yes. Oh my gosh. I could talk for like 5 hours on this topic. It's so interesting. It's a huge area of research, area of interest, and giant area of frustration for people who are dealing with patients in the eating disorder community. They are frequently a drug of abuse, and I should have listed them on that, compensatory behaviors kind of thing. So I recently saw a patient who was getting 4 different compounded GLP-1s from 4 different providers. At the maximum dose. And so if a patient knows that this is going to help them change their body, of course they're going to reach for it, and you can get it anywhere. You can get it on any street corner. So that's a big problem. I will say, and these patients, it's very dangerous for some of them to use GLP-1s. We know that GLP-1s increase the risk of reflux, aspiration, small bowel obstructions. As you can imagine, a patient who is binging and purging, they're already at high risk for those things. And then you're adding something that makes it worse. There is active research being done and discussions about how GLP-1s quiet the food noise. And I'm sure you've all seen this, heard this from patients and seen it on social media. It does. And I have patients who've had trouble with binge eating disorder or bulimia who have been started on these things by outside providers. I have a very, love-hate relationship with those drugs, but, and they do say, like, I can avoid binging, right? But the problem is they're also, which I certainly, I want them to not suffer, right? But they're also not dealing with any of those underlying issues or really food behaviors. And when they stop the GLP-1, that all of that stuff comes roaring back. So I feel like we're doing the patients a long-term disservice if they have any kind of broken relationship with food to start those medications. Did that answer the question? I hope.
Yes, thank you. I agree. I feel like we could do multiple sessions on this topic. It's so new and emerging.
And it's
We
probably going to be different in 6 months than it is now. And yeah.
Yes, and so many different viewpoints too. It'd be fun to have a debate.
Yeah.
We had a bunch of questions about resources. So, do we have a list of qualified providers for ED treatment? I primarily refer to Center for Change, but would love some more options. And then, are there therapists that specialize in the treatment of ARFID in the Valley as well?
That's a really good question. So I will say there's a really wonderful and active group that's called Eating Disorders Professionals of Idaho. Many therapists, dietitians, a couple of us physicians, and a few psychiatry and even one physical therapist who participate in that group. They have, and I will get it to everybody, an email that they've started to do. This has always been kind of more of an informal group, but they've started to have an email that you can say, hey, I'm looking for a therapist for this particular type of patient or whatever you're looking for. And in this area of the state. And so they do help with that. I know Center for Change also does that. And EDPI, the Eating Disorders Professionals of Idaho, they intentionally don't, like list those people on their website because it is shifting and they're trying not to, promote a specific practice. And the other question was about ARFID. I think I would say that tends to be, maybe some therapists are more comfortable with that than others, but if they have training in eating disorders, I think I don't necessarily make a distinction about somebody with that particular eating disorder versus another one, because again, as soon as they get into recovery, that body image distress does sometimes come up. And so I don't know that the approach is hugely different. And please correct me if you think I'm crazy on that.
Thank you, Katie. A follow-up from the GLP-1s. I have clients coming in and being so excited about finding these meds. Folks have not been so happy to talk about it, GAP1 stuff, unless it's equal excitement from me.
Hmm.
And then Catherine said, I have had clients find success in ARFID treatments with referrals to occupational therapy. Oh, and she said GLP-1 stuff. So I'd love to just take a couple minutes to open it up for questions about the content of Katie's presentation before we move on to case stuff. So we've got a few minutes here. Any questions?
Shannon, while everybody's trying to decide if they have a question, can I say one more thing about kind of going back to the nutritional supplements question? I think it's always important to meet patients where they are in terms of what they can eat. And sometimes it's very limited, but I always say first we get enough of whatever it is. And then second, we start to try to work on, the variety. And so, yeah. So if they're only eating one thing, first they try to eat more of it.
I love it. Okay, so first question in the chat from Andrew Baker. How often should labs be monitored?
It really depends on what the patient's behaviors are. If a patient is purely restricting, as I mentioned, labs are really not all that helpful. I do um, but if they're purging, and especially if they're purging very frequently, those electrolytes can change and can change frighteningly over a short period of time. So that's not really a definitive answer, but I would say in patients who are purely restricting, I'm looking at much more at vital signs. I'm looking at what's their heart rate, what's their blood pressure, what's their temp, and of course weight trajectory. And we do all blinded weights in our office, and I know that's a whole thing if anybody wants to talk about it. Frequently in the adolescent medicine clinic, I know they share the weight, but that's part of a family-based therapy approach. But I will always do baseline labs because I want to make sure that they don't have another underlying medical disorder that's contributing. And so we're looking at CMP, MAG, FOS, CBC, thyroid tests, SED rate, sometimes celiac testing, oftentimes things like B12 and iron. And I do a leptin level on patients whenever I see them. So leptin is a gut hormone that often is suppressed much more so in patients who are of low body weight and restrict. So it's not always helpful, but it kind of gives me a 30,000-foot view. And then hormones. So in patients who make testosterone, whether they're binary, non-binary or not, we're always checking testosterone levels. We're checking FSH and LH, and then in genetically female patients, we're checking who are not on hormones. We're checking estradiol and FSH and LH. And then in patients who only restrict, I'm probably only checking labs quarterly unless I have some other suspicion. In patients who purge, I've seen patients who purge 6 times a day. We're checking them, sometimes weekly while we're trying to do something different or get them into a safer situation.
Excellent. And then one more question, and then we'll go to kind of the case questions. What treatment standards exist for treating trans patients?
That's tough. As I said, and I'm sure Tara could talk a lot more, authoritatively about this, but the eating disorder, especially higher levels of care, really has been structured as, women can go anywhere, men can go to a few places, but now, that really doesn't work in the world we live in now. And so I think it is adapting. But there are still, I just had a male patient, a cisgender male that I was trying to get into a higher level of care, and it was really challenging. And so I would say that's a work in progress.
Thank you. Okay,
And I will admit too, let me say one more thing about that. I will admit that I don't think I do a great job with that in my practice. It makes me feel like a really old doc when I see those patients. I'm like, okay, well, let me, stumble my way through this. So it's definitely a work in progress for me as well.